An AI scores 95% on the medical board exam. Then a patient walks in and describes vague chest tightness that started 3 weeks ago, and the AI asks, "Do you have chest pain?" That is not a follow-up question. That is a restatement of the chief complaint. And a physician knows, any medical student knows that the follow-up question is, does it radiate? Is it worse with exertion? Do you have associated shortness of breath? Has anything like this happened before? The AI that just aced the boards cannot find those questions. And that tells us something that should fundamentally change how we evaluate AI in medicine. Here's a confession. Every time I see a headline saying an AI has achieved physician-level performance on a medical benchmark, I read the methodology section before I read the results. Because the number means almost nothing without understanding what the benchmark actually measured. The dominant benchmark for medical AI over the past several years has been MedQA. It is derived from USMLE style questions, the same boards that US physicians take to get licensed. It presents a written case vignette, usually a paragraph or two, with all the relevant history, exam findings, and diagnostic data already structured and presented. You pick the best answer from 4 or 5 options. MedQA tests something real and valuable, medical knowledge and clinical reasoning from a complete information set, but it does not test something that is equally real and equally essential, the ability to gather that information in the first place. The ability to ask the right questions, in the right order, to a patient who does not know what is relevant, and who is scared and possibly not describing their symptoms accurately. That gap between reasoning with complete information and gathering incomplete information through an interactive history is the gap the AI hospital benchmark was built to measure. The paper comes from a collaboration between Alibaba, Fudan University, and Zhejiang University of Science and Technology. It was published in February 2024, and the headline finding is one of the most important and most underreported numbers in the AI and medicine literature. In interactive, multi-turn clinical encounters, the best AI systems score less than 50% of what they score when given the full case at once. Less than 50%. That means a model that scores 90% on a written case vignette might score 45% when it has to figure out the relevant details through a real conversation. Half the apparent capability disappears when you add the human interaction layer. Let me walk you through the AI hospital architecture, because it is genuinely elegant, and I think understanding it will change how you evaluate every AI clinical claim going forward. The framework creates a dynamic role-play environment with 4 agents. First, there is the doctor agent, the AI system being evaluated. Second, there is the patient agent, an NPC, a non-player character implemented with GPT 3.5, given a disease profile and a patient backstory, and told to respond to clinical questions the way a real patient would, including being vague, including forgetting things, including mentioning the relevant detail only when directly asked. Third, there is the examiner agent. This returns lab results, imaging findings, and examination results when the doctor agent orders them. Fourth, there is the chief physician agent, implemented with GPT-4, playing the role of an attending physician who evaluates the doctor agent's performance at the end of the encounter. The doctor agent must conduct the encounter the way a real clinician does. Ask questions, gather history, order appropriate tests, review results, and arrive at a diagnosis. It cannot skip to the answer. It cannot read the whole case at the start. It has to navigate the dynamic conversation. The benchmark they call MVME, Multi-View Medical Evaluation, evaluates the encounter across 3 dimensions. Symptom collection. Did the doctor agent gather the relevant history? Examination selection. Did it order the right tests and avoid unnecessary ones? Diagnostic accuracy. Did it arrive at the correct diagnosis? And the results, when they ran the best available models through this framework, were humbling. On symptom collection, the most fundamental clinical skill, asking good follow-up questions, the models consistently failed to identify important symptoms that any experienced clinician would have elicited. They asked generic questions. They missed lateralizing symptoms, timing, severity scales, associated features, red flags, the things that differentiate a benign condition from a serious one, the things that separate a good history from a bad one. The paper also introduces what they call a dispute resolution collaborative mechanism, a system where multiple doctor agents examine the same case and debate their findings, with a center agent resolving disagreements. The idea is that collective deliberation improves diagnostic accuracy, which it does. But even with deliberation, the interactive performance gap remains striking. I want to take a few minutes to explain from a clinical perspective what actually happens during a good clinical history. Why? Because I think this will make the benchmark results more viscerally meaningful. When an experienced physician takes a history, they are doing several things simultaneously. They are gathering explicit information through direct questions. They are noting what the patient is not saying or is minimizing. They are observing nonverbal cues, affect, body language, how the patient moves. They are building a running differential diagnosis, and they are using that differential to guide the next question. Every answer constrains the probability space of what is going on, and the next question is chosen to maximally discriminate between the remaining possibilities. That last piece, using the current differential to guide the next question, is what the AI systems in the AI hospital benchmark mostly fail at. They ask generic questions in a predictable sequence because they do not have a dynamic probability model updating in real time based on the patient's responses. Or if they do, they cannot translate that updating model into a coherent conversational strategy. In physical medicine and rehabilitation, in regenerative medicine, this matters acutely. When I am evaluating a patient for a potential PRP injection, my history is not a standard orthopedic intake. I am asking about inflammatory markers, about prior injections and their duration of effect, about functional limitations in daily life. I am trying to understand whether the pathology is appropriate for a regenerative approach and whether their expectations are calibrated. That is a nuanced, multidimensional conversation. A system that can answer MedQA questions accurately is not necessarily the same system that can have that conversation with a patient. The distinction matters for patient safety. A system that scores high on knowledge but low on interactive history taking creates a specific danger. It will appear knowledgeable and confident, but it will systematically fail to pose the right questions to itself. It knows the answer, it cannot find the question. The AI hospital benchmark is important precisely because it makes this failure mode measurable. You cannot fix what you cannot measure. Let me translate this into practice implications because I think the AI hospital findings have direct consequences for how we should think about deploying AI clinical tools. The finding has a clear implication for patient-facing AI. Any AI system that interacts directly with patients for history taking should be evaluated on interactive benchmarks, not just static QA performance. A system that scores brilliantly on MedQA and then cannot elicit a complete history is not just a worse tool, it may be an actively dangerous one. Because clinicians who trust the AI-generated history will make decisions based on an incomplete picture. This is why I am skeptical of certain implementations of AI scribes and AI intake tools that report only their documentation accuracy, i.e., their ability to turn a spoken conversation into a clean note without reporting on their ability to supplement or extend that conversation. The note-writing part of AI documentation is genuinely impressive and generally safe. The history-taking part is harder, and the benchmarks do not support the same level of confidence yet. The dispute resolution mechanism in AI hospital is actually the most clinically interesting architectural innovation in the paper. And I think it points toward how clinical AI should be deployed for complex cases. The idea that multiple AI agents reason independently and then reconcile their findings, with a supervisory agent moderating the deliberation, mirrors how good medical teams actually function. It is not one doctor making every decision unilaterally. It is a team of consultants, with a primary physician coordinating. In a multi-specialty practice, that architecture is directly applicable. An orthopedic AI agent, a physiatry AI agent, and a regenerative medicine AI agent could each independently assess a complex musculoskeletal case and submit their findings to a synthesizing agent, with a physician reviewing the aggregate output. That is more robust than any single model, and it mirrors the clinical reality that the hardest cases benefit from multiple expert perspectives. Hippocratic AI's Polaris constellation model takes a similar approach. Multiple specialist AI agents working in coordination, with explicit safety guardrails. Hippocratic is currently one of the most widely deployed clinical AI vendors in 2026, precisely because they built the safety and collaboration architecture before they built the capability claims. I want to give you something practical to take from this episode. If you are a clinician evaluating an AI tool for your practice, or a patient wondering whether the AI your provider is using has been properly tested, here's the question I would ask. How does the system perform on a dynamic, interactive patient encounter, not on a static QA benchmark? Any vendor that cannot answer that question with specific benchmark data is selling you a system that has been evaluated on the easy version of the clinical task. Med-QA performance is necessary but not sufficient. Interactive performance is the harder test, and it is the one that maps to what the system will actually do when a real patient starts talking. The AI Hospital Benchmark is open source. The code and the framework are on GitHub at the libertfan/AI_hospital repository. If a vendor cannot tell you their system's MVME scores or cannot produce comparable interactive evaluation data, that is a meaningful signal. I say this not to be an AI skeptic. I am not an AI skeptic, as I hope this series makes clear, but to be a scientifically rigorous physician. The same standards of evidence we apply to clinical interventions should apply to the clinical tools we use. Efficacy in a controlled trial is not the same as efficacy in practice. Performance on a static benchmark is not the same as performance in a dynamic clinical encounter. The AI Hospital Benchmark is one of the most important contributions to the field of clinical AI evaluation. Not because it found a problem, though it did, but because it named the problem precisely: the gap between clinical knowledge and clinical communication. Knowing medicine and doing medicine are different skills. The benchmark makes that gap measurable for the first time. As clinicians, we have always known this. You can have a medical student who knows every diagnosis and Harrison's principles and still be unable to get a history from a real patient. Knowledge and communication are both trainable, but they are different skills. AI development has spent years optimizing the knowledge side. The AI Hospital Benchmark is a call to optimize the communication side with equal rigor. Next week, I'm going to give you the architectural answer to this problem. If the issue is that natural language intent does not translate cleanly into structured clinical action, the solution is a compiler, a layer that sits between what the physician says and what the system executes. That layer is what Junda Wu and Jared Zhu at Oxford call the medical operating system, and understanding how it works will give you a new way of thinking about every clinical AI tool you encounter. Thank you for watching this episode of the Medical Operating System.